My brain had begun to endure its familiar siege. My thought processes were being engulfed by a toxic and unnameable tide that obliterated any enjoyable response to the living world. William Styron wrote these words to relate his own personal experience with depression. What he describes is a psychological and physical struggle with a mood disorder. So, what do I mean when I say mood disorder? In the context of a mental state exam, a patient's affect is the manifestations of emotion observed by an objective, third party stance, such as that of a doctor. This contrasts with mood, which is the subjective and persisting tone of feeling experienced by the patient, his or herself. Mood is a spectrum ranging from despair to euphoria, and it's normal to experience a full range of emotion over the course of a lifetime. However, if these emotions are persistent, severe, or associated with psychotic or suicidal features, mood is said to be disordered. The ICD-10 currently outlines a number of different mental illnesses as mood disorders, the two principal ones being major depressive episodes and bipolar affective disorder. So let's first consider depression. Major depressive episode is characterized by low mood, low energy, and a loss of interest for a period of at least 2 weeks. A constellation of other symptoms associated with depression include feelings of guilt and worthlessness, sleep abnormalities, and psychomotor retardation, all of which can impact on a patient's social functioning. The lifetime prevalence of depression is 17%, although the disorder is twice as common in females compared with males. Currently, the World Health Organization reports depressive illness as a leading cause of disability and estimates that by the year 2030, depression will be the leading cause of global disease burden. On top of this, it is now recognized that depression is an inflammatory condition with elevated levels of the stress hormone cortisol in patients' serum. This makes depression an independent risk factor for heart disease and adds to its global disease burden. Depression is associated with functional decreases in the limbic system and neocortex of the brain. These neural areas regulate emotional responses and a number of neurobehavioral processes, and this helps to explain the features of depression. The monoamine hypothesis of depression is that these neural pathways are deficient in the neurotransmitters noradrenaline and serotonin. Environmental triggers, such as adverse life events, can trigger depression, especially those with a family history of a mood disorder. Before diagnosing depression, consider organic causes such as anemia, hypothyroidism, chronic steroid use, or intoxication. Another psychiatric disorder to consider is an underlying depressive episode of bipolar disorder. Goals of management should include the alleviation of acute symptoms, the restoration of psychosocial function, and the prevention of relapse. Treatment for depression is dynamic and depends on patient factors and individual biological responses to medication. Non-pharmacological measures recommended include exercise, substance and alcohol reduction, and psychological therapies such as cognitive behavioral therapy, which has been found to be equal to medication in the efficacy of treatment for mild to moderate depression. Pharmacological management targets the synapses of the brain. In limbic and neocortical pathways, serotonin and noradrenaline are secreted by presynaptic neurons to potentiate signals relating to emotional information. Levels of these two neurotransmitters in the synapse are reduced through degradation by monoamine oxidase or else by reuptake into presynaptic cells. The first-line management of depression is with antidepressants of the selected serotonin reuptake inhibitor family, which elevate levels of serotonin in the synapse by preventing their reuptake. Other antidepressants include serotonin noradrenaline reuptake inhibitors and tricyclic antidepressants, both of which also prevent monoamine reuptake. If symptoms are persistent despite a number of different treatments being tried, this may be an indication for the use of a monoamine oxidase inhibitor. However, due to the interaction of these drugs with foods containing the amino acid tyramine, their use is generally avoided first or second line. Antidepressants take up to 6 weeks before therapeutic concentrations reach effective levels, but initial response may be observable earlier. The side effect profiles for antidepressants are large, and so it's important to notify patients of a potential for adverse events. It's important to note that adolescents are at higher risk of suicide with SSRIs, and that TCAs can be cardiotoxic, so ECG monitoring is always considered. Where depression is severe and other managements have failed, or where the disorder is life-threatening, electroconvulsive therapy is recommended and has a high treatment success rate. What may seem like major depression is also a presenting feature of a very different illness termed bipolar affective disorder, which alternates between depression, periods of normal mood, and periods of mania. Mania is defined as a period of at least a week in which individuals experience either strong feelings of euphoria and invincibility, or else dysphoria with irritability. It's typical that these symptoms begin to present for the first time in early adulthood. Other features may include delusions, hallucinations, and the characteristic pressure of speech with playful associations called punning or flights of ideas. A great example of these and other features of mania come from the work of Kay Redfield, a psychologist who herself has bipolar disorder. The lifetime prevalence of the disorder is approximately 1% throughout the world, and the disorder has an equal gender ratio. Adoption studies and higher risks of developing bipolar if a first-degree relative is affected implicate genetic components involved. Of course, the etiology of the disorder is complex and works within a biopsychosocial framework, involving interactions between genetic loading and environmental insults such as major life stress. Again, monoamines in the brain synapses are shown to have complex relationships with presenting symptoms of individuals with bipolar disorder. For example, mania can result from increased dopamine activity in reward pathways, so that manic individuals are more likely to spend or gamble money. Diagnostic criteria most often fall into the two main categories of bipolar type 1 and type 2 disorder. Type 2 is distinguished from type 1 through the definition of hypomanic episodes. Hypomania is a period of manic symptoms for 4 days or less without psychotic elements and which do not significantly impair social or occupational functioning. Management goals for bipolar disorder are similar to those of depression, namely that patients should be an informed and active member in the decision-making process. Antidepressants provide the danger of converting a depressive episode into a manic one, and so their use is generally avoided with bipolar disorder. The mainstay of treatment for mania is with mood stabilization using lithium and anticonvulsants. These are both used in the acute phase and as maintenance therapy for relapse prevention of mania. Lithium concentration has a narrow therapeutic range, and blood monitoring is necessary. Furthermore, lithium is nephrotoxic and has a range of GI side effects. Sodium valproate is teratogenic and should be avoided in women of childbearing age. Sedatives and antipsychotics may be beneficial in the acute phase due to their more rapid effects. However, it's important to consider their wide array of side effects. Complications of untreated mood disorders include isolation and even self-harm or suicide, which will be covered in another video. For these and many other reasons, it's important to correctly identify diagnoses and initiate management in conjunction with the patient.